আমাদের আজকের লেকচারের বিষয়বস্তু হলো ডায়রিয়াল ডিজিজেস, কনসাইজ অ্যান্ড আপডেটেড এটিওলজি, ল্যাবরেটরি ডায়াগনোসিস অ্যান্ড ট্রিটমেন্ট। Diarrheal diseases belongs to gastrointestinal tract infection and are among the most common infective syndromes. About 170 to 500 crores episodes of diarrhea occur every year worldwide, of which 12.7 lakh dies. In developing countries, more than 6 episodes of diarrhea in infants and an average 3 episodes in children less than 5 years occurs annually. And in developed countries also, diarrheal diseases are a significant cause of morbidity in all age groups. Clinical symptoms of gastrointestinal tract infection includes diarrhea, dysentery, vomiting, food poisoning, peptic ulcer disease, necrotizing enteritis, necrotizing enterocolitis, pseudomembranous colitis, of which we will address diarrhea, dysentery, food poisoning, vomiting, and pseudomembranous colitis. Diarrhea, according to WHO, there are acute diarrhea, persistent diarrhea, and chronic diarrhea. Acute diarrhea is defined as passage of 3 or more loose stools per day in excess than usual habit for that person and lasts less than 14 days. Persistent diarrhea is an episode that lasts longer than 14 days but less than 30 days. And chronic diarrhea, an episode that lasts longer than 30 days. There is another classification of diarrhea based on severity: mild, moderate, and severe. Mild, minimal associated symptomatology with minimal interference with activities. Moderate, there is with or without systematic symptoms but interferes with planned activities. Severe, there are systemic manifestations plus tenesmus and blood or fecal leukocytes. Diarrhea etiologies can be classified on the basis of acute, persistent, and chronic. Acute, as we have said, it is less than 14 days duration, mostly viral, but severe cases can be caused by bacterial and by protozoal. We will discuss their names in the next slides. Persistent depends on exposures and travel history. They may be due to Giardia, Cryptosporidium, Entaimvestilatica, maybe Cyclospora, maybe strongyloid schistosomiasis, Cryptosporidium in daycare centers, Clostridium difficile if hospitalized or on antibiotics, cytomegalovirus or microsporidia in immunocompromised, especially HIV positive patients. Chronic diarrhea cause varies depending on socioeconomic factors and is often not infectious. It may be infectious and non-infectious. If infectious, it may be due to Clostridium difficile, Aeromonas, Plesiomonas, Campylobacter, Giardia, Entaimvestilatica, Cryptosporidium, and Cyclospora. Non-infectious causes include irritable bowel syndrome, inflammatory bowel disease, malabsorption syndrome, and post-infectious irritable bowel syndrome. Let us discuss the infectious etiologies of diarrhea. There may be bacterial, parasitic, and viral causes. Viral causes are few: rotavirus, norovirus, and adenovirus. Parasitic causes are also not that much: Entaimvestilatica, Giardia, Microsporidia, Cryptosporidium, recently added Cyclosporidia and Cystospora belli. These are recently added. And the bacterial causes include Shigella, Salmonella, Campylobacter jejuni, Clostridium difficile, Vibrio, diarrheogenic Escherichia coli that includes enterotoxigenic, enteropathogenic, enterohemorrhagic, enteroaggregative Escherichia coli. In this, there are 5 or 6 varieties of Escherichia coli. Klebsiella oxytoca, recently, they are also producing diarrhea, toxin producing diarrhea. Laboratory diagnosis of GIT gastrointestinal diseases. This traditional thing is, it is based on microscopy, culture, immunological as well as molecular biological test. A specimen, of course, stool and rectal swab. Diagnostic methods includes microscopy, direct smear, iodine preparation, modified gel Nielsen stain smear, mostly parasitic diarrhea, and the nature of the diarrhea can be assessed by microscopy, presence of pus cell and RBC and Entahistolytica, Giardia, Cryptosporidia, etc. Culture, media, and incubation environment varies with suspected pathogen. If Salmonella, Shigella, then SS agar media or McConkey. If Campylobacter, jejuni, then different media, and environment is also incubating environment is also different. Molecular test nowadays very popular. The real-time multiplex PCR. There are biofar film array, the syndrome-based test that includes 70 virus and 3 bacteria in a single panel. Antigen detection tests are also available, rotavirus and norovirus, Vibrio cholerae, like this, Giardia. There are antigen detection tests for different protozoal and viral diseases. Let us discuss the diagnostic criteria of diarrheal disease. As we have said, multiplex molecular panels are largely replacing culture and microscopy for initial detection of potential pathogen. And due to their sensitivity, specificity, ease of use, and rapid turnaround time, then they are becoming very popular. Stool culture still we are needed because antibiotic susceptibility testing can be done after culture and for public health disease tracking. And diagnostic studies should be targeted only for those with bloody diarrhea or severe illness or symptom duration more than 7 days or immunocompromised host. In other cases, we don't need the diagnostic studies. For travelers, multiplex molecular panels should be used when symptoms fail to resolve after empiric trial of azithromycin. For hospital onset diarrhea, it should be begun with targeted testing for Clostridium difficile. And multiplex testing can be reserved for severely immunocompromised patient. And the result of multiplex PCR should be interpreted with caution and consideration of clinical context. As the PCR panel are very sensitive and may detect organisms that may or may not be causing symptoms, just they are present, colonizer. For example, detection of EAE gene for EPEC has not been shown to correlate with presence of diarrhea, and detection of Clostridium difficile DNA gene also may represent disease or asymptomatic carriers. These are the pathogen which can be detected by rapid molecular microarray. Among the viruses, adenovirus, astro, norovirus, rota, and sepovirus. Among the parasites, Entahistolytica, Giardia lamblia, Cyclospora, and Cryptosporidium. Among the bacteria, all the common bacteria are there: Campylobacter jejuni, coli, Clostridium difficile, toxin A, B, Pseudomonas, Shigella, Yersinia, Vibrio cholerae, Parahemolyticus, Balnificus. Among the bacteria, there are all types of diarrheogenic Escherichia coli like enteropathogenic Escherichia coli, enterotoxigenic, enteroinvasive, Shiga toxin producing Escherichia coli, enteroaggregative, and E. coli 017. Let us discuss about the treatment, empiric treatment as well as targeted treatment. Empiric treatment, if it is mild diarrhea, only hydration, that is fluid, and lactose-free diet is needed, and they should avoid the caffeine. If it is moderate diarrhea, fluid plus anti-motility agent, loperamide 4 gram per oral, then 2 gram, 4 milligram per oral, then 2 milligram after each loose stool to maximum 16 milligram per day, and bismuth subsalicylate 2 tablets per oral 4 times a day. They should not be used in hemolytic uremic syndrome, and anti-motility agent generally not advised in Clostridium difficile toxin mediated diarrhea. In case of severe diarrhea, ciprofloxacin 500 milligram twice daily, or levofloxacin 500 milligram once daily for 3 to 5 days only, or azithromycin 1 gram once daily, or 500 milligram once daily, 1 gram only once, 1 tablet, or 500 milligram once daily for 3 days. And they are preferred for Campylobacter and disease acquired in Southeast Asia. If Clostridium difficile is suspected, vancomycin is to be added, or fidaxomicin 200 milligram twice daily for 10 days to be added. Antibiotic stewardship, the use of molecular diagnostics to detect potential pathogens can result in fewer days of empiric therapy and more focused antimicrobial therapy, which in turn should improve the safety and efficacy of treatment regimen. These are some epidemiologic and clinical feature of a specific pathogen-associated diarrhea. Staphylococcus aureus food poisoning, characterized by a rapid onset of nausea and vomiting with or without diarrhea, and it occurs within few hours of taking contaminated food. Enterotoxigenic or enteroaggregative Escherichia coli, if it is of less than 7 duration, there should be a history of travel to developing countries. Shigella, Salmonella, Entaimba histolytica, Campylobacter, usually characterized by bloody diarrhea. Shigella, Giardia, norovirus, and rotavirus, usually there is history of daycare center acquisition. Salmonella, non-typhoidal Salmonella, must have history of raw and undercooked egg, reptile. Campylobacter, Clostridium difficile associated with the recent history of antibiotics or hospitalization. Vibrio, usually associated with ingestion of untreated fresh water or contaminated water, seafood or seawater exposure. Aeromonas or Plesiomonas, same history. Norovirus, cruise ship or daycare center acquisition history. Giardia, they have got history of drinking from untreated natural bodies water. And there are some suggestion of specific treatment of a specific pathogen associated diarrhea. If Staph aureus food poisoning, no antibiotics needed, only symptomatic management. If Campylobacter, azithromycin 500 milligram once daily for 1 to 3 days if the patient's age is less than 6 months or more than 50 years. If enterotoxigenic, enteropathogenic, or enteroinvasive Escherichia coli, then ciprofloxacin 500 milligram twice daily for 1 to 3 days. If it's Shigella, then cotrimoxazole twice daily, or ciprofloxacin once daily, twice daily for 1 week. Non-typhoidal Salmonella, ciprofloxacin 500 milligram twice daily, cotrimoxazole or ceftriaxone, cotrimoxazole twice daily, or ceftriaxone 1 gram once daily for 5 to 7 days. If Vibrio parahemolyticus and patient is severe illness, then ciprofloxacin 500 milligram for twice daily for 1 to 3 days. In case of Clostridium difficile, the offending antibiotic should be discontinued, and fidoxomicin for preventing the recurrence. In case of Entaimba histolytica, even asymptomatic patients should be treated. Metronidazole 750 milligram twice daily for 5 to 7 days, or tinidazole 1 gram twice daily plus paromomycin 500 milligram thrice daily for 7 days. Giardia, metronidazole 250 to 500 milligram twice daily for 7 to 10 days, or tinidazole 2 gram single dose. So thank you very much.